Thanks very much, Lindsay, for that introduction. Hi, I'm Jen Boyd, a PhD student at the University of Sheffield on the Wellcome Trust Doctoral Training Programme. So first, thanks for giving me the opportunity to present some of my work to you today. I'm going to talk a bit about some of the work I'm doing as part of my wider PhD project, which focuses on how health inequality theory could enhance our understanding of the alcohol harm paradox. And I also just want to thank my co-authors here, so Claire Bamborough at the University of Newcastle, and Robin Pursehouse and John Holmes at the University of Sheffield, and my funders, the Wellcome Trust. So I thought I'd start by setting out the aims of this webinar. So the webinar will be split into 3 sections, with some time for discussion between each section. So first I want to cover a bit of background on the alcohol harm paradox, explaining what it is and giving a bit of an overview. Then the second section will focus on sharing some insights from a paper that we've written, which talks through applying existing health inequality theory in the context of the alcohol harm paradox. And I'll describe what some of these theories are before going on to link these theories with findings from my recent review, which aim to provide an overview of a breadth of explanations given for the alcohol harm paradox. Following this, in the last section, I'll discuss some of the research and policy impacts that we think result from using health inequality theory to understand inequalities in alcohol harm. And I'm really looking forward to some discussion and hearing your thoughts around what you think causes the paradox and whether this fits with health inequality theory. So I thought I'd start with a brief introduction to what health inequality is. Health inequalities are no doubt important, and maybe a few people will be familiar with this definition by Margaret Whitehead, which says that health inequalities are systematic differences in health between different socioeconomic groups within a society which are socially produced and therefore potentially avoidable and widely considered unacceptable in a civilised society. As I'll cover in this talk, alcohol is subject to major health inequalities, and the alcohol harm paradox is a special example of this. So the first section of the talk is going to focus on what is the alcohol harm paradox and how have we tried to understand it. So I wanted to include a key point slide for each section, things I hope you'll take away from the webinar. So I hope by the end everyone will be familiar with what the alcohol harm paradox is. And it's the consistent finding that poorer people suffer more harm from their drinking than richer people. That is that even though on average poor people drink the same or less as rich people, they still have greater rates of harm, for example, alcohol-specific and related deaths. The second key message from this bit of the talk is that alcohol consumption does contribute to harm, but can't completely explain the alcohol harm paradox, which might seem obvious from the description, but it's important to note that this is in reference to drinking patterns. So the idea that maybe poorer people drink more on one day, while richer people might drink less, but more frequently. So the last key point from this section is that people interested in why there are inequalities in alcohol harm have discussed lots of explanations, and I'll talk a bit more about these later. However, research has tended to focus on looking at how risk behaviour, so things like smoking and bad diet, contribute to the excess harm experienced by poorer people. So what does the alcohol harm paradox look like then? Well, this graph, which has been taken from the Understanding Glasgow project's website, shows the differences in alcohol deaths between deprivation quintiles. Deprivation quintiles categorise areas based on a number of factors, including income, employment, education, housing, and others. And this creates a rank of the most deprived to the least deprived areas, or in other words, the worst off to best off areas. It might be a bit hard to see, but the top line with the diamond markers are the most deprived or poorest people. And you can see that the number of deaths is greater for the most deprived. Specifically, this seems to really increase after the start of the 1990s, while the number of deaths in the least deprived or richest group, and that's the line at the bottom, is the lowest. This relationship seems to be stepped, so the second most deprived experiences the second highest number of deaths, and so on. Now, keeping that image in your head, let's have a look at alcohol consumption. So you can see these bars represent the most deprived to least deprived quintiles again, or the poorest to the richest, with the poorest on the far left and the richest on the far right. And you can clearly see that alcohol consumption doesn't look that different between the groups. The poorest group report that their weekly average alcohol units consumed are 11, while the richest are reporting 12 units on average per week. But we know that the most deprived are experiencing higher numbers of alcohol deaths, and that's what we see in this previous graph here. This is the alcohol harm paradox. It's the consistent finding that poorer people suffer more alcohol harm while drinking the same or less than richer people. And this relationship is found time and time again in several countries, including the UK, Australia, the Netherlands, Finland, and so on. So some of you might be thinking that maybe we only see this relationship because there are more people who don't drink at all in the more deprived groups, which brings down the average level of alcohol consumption for that group. And while evidence does suggest that there are more people that don't drink in disadvantaged groups, research has shown that this is not why we see the alcohol harm paradox. The data for this table was taken from a paper published by Vital Katikareddy and colleagues at the University of Glasgow, which explored the relationship between socioeconomic position, alcohol consumption, and alcohol harm using linked record data. And this is just data that's obtained from the same person at 2 different time points. So in this case, initially socioeconomic status and health behaviours were collected, then the hospital and death records for the same people who had responded to the survey were obtained for the following years. I made this table just to make it a bit easier to interpret, but basically you have 2 columns, one which represents rich people or high socioeconomic status, and the other which represents poor people or low socioeconomic status. These are then split into never or ex-drinker, light drinker, moderate drinker, heavy drinker, and excessive drinker. The risk values are hazard ratios, but I'm not going to go into detail explaining this. The gist is that the higher the value is, the higher the risk that someone in that group will be hospitalised for alcohol or die from an alcohol-related cause. And you can see that at every level of alcohol consumption, the risk of alcohol-related hospitalisation or death is greater for those of a low socioeconomic status compared to high. And if you just look at the risk for never or ex-drinker, it's just about double for lower socioeconomic groups compared to high. So there's been a lot of research done which has identified and confirmed the existence of this paradoxical relationship between socioeconomic position, alcohol consumption, and harm, investigating whether the relationship holds across contexts, so between countries or gender, and when using different measures of socioeconomic position. So now that we can say that the relationship is robust, how have we tried to explain it? And by this I also mean, where have we invested research efforts to uncover the cause or causes of the alcohol harm paradox? So there are 3 prominent explanations in the field which have so far dominated the research efforts of those investigating the alcohol harm paradox. The first is consumption patterns. And this is the idea that lower socioeconomic groups engage in higher rates of binge drinking, so they drink greater volumes of alcohol on one occasion rather than drinking less more frequently, as is done by higher socioeconomic groups, which may result in excess harm. The second is that lower socioeconomic groups engage in multiple unhealthy behaviours alongside alcohol consumption, so they smoke, eat unhealthy, and don't exercise, and this increases their risk of harm. And finally, the third is methodological issues, which is focused on study design, and is the idea that lower socioeconomic groups don't accurately report what they drink. So when they're asked how much alcohol they consume, they underestimate it compared to higher socioeconomic groups. However, while these explanations have dominated research, the evidence suggests that these individual factors can't explain the alcohol harm paradox. Binge drinking, BMI, and smoker status do contribute to the excess harm experienced by lower socioeconomic groups. But even when accounting for this, they remain at a higher risk of alcohol-related harm, with one study focused on a Scottish population highlighting that the risk remained 3 times higher after controlling for these risk behaviours. In the case of underreporting, some research has been done which highlights that those of a high socioeconomic position are just as, if not more likely to underreport their alcohol consumption by excluding alcohol they consumed at special events, such as weddings, or on holidays. Therefore, the causes of the alcohol harm paradox remain unclear. While drinking patterns, engaging in multiple unhealthy behaviours and underreporting of alcohol consumption have been the focus of research efforts, the Institute of Alcohol Studies outlined two other potential explanations in their overview of the alcohol harm paradox: materialism and access to healthcare. The material circumstances in terms of social, economic and environmental factors are thought to provide a protective benefit, and therefore those with fewer resources are less well protected from the experience of a problem or the impact of a stressful event, which results in worse health outcomes. Material circumstances can also have a direct impact on health, as those living in worse conditions have an increased risk of developing a health condition. In terms of access to healthcare, it's well known that those living in deprivation face greater barriers to accessing services, and this can be through cost, distance, availability, and stigma. These mechanisms and others associated with inequality may be intrinsic to the alcohol harm paradox, but have yet to be addressed in research. So the presence of so few visible explanations prompted me to conduct a review which aimed to identify explanations for the alcohol harm paradox from the literature, both from academic articles and other documents such as government and third sector reports. This aimed to prompt a wider focus by identifying a breadth of explanations used in the literature, including explanations which aren't commonly explored in alcohol research. I also wanted to group the explanations into groups and explore how and if authors link the explanations together. Finally, I wanted to look at the evidence for the explanations I found. First, to see if there was any evidence, and if there was, to discuss whether this supported or did not support the explanation it was testing. I used the results from this review in the paper that I'm going to talk a bit about later today. So just to give you an idea of the number of explanations that exist for the alcohol harm paradox, I thought I would show you this diagram. Based on our review, we found 41 distinct explanations which fell within 16 themes. And I'm not going to go into detail about this, but every circle in the diagram represents a theme, and the lines represent where an author combined an explanation belonging to one theme with an explanation in another. These themes then fit within 6 broad domains, which were artifact, and this was the idea that the alcohol harm paradox doesn't actually exist, but we see this relationship because of issues with study design. Lifestyle, which was about how a multitude of bad health behaviours could explain why the alcohol harm paradox exists. Individual, which was about the biological and psychological factors like genetic makeup and more stress that predispose poorer people to more harm. Contextual, which was more about how poorer people may drink and alcohol in more dangerous environments, and this might contribute to harm. Disadvantage, and this was about the lived experience of disadvantage and things like worse access to preventative and treatment services. And finally, upstream, which was just about how structural factors such as the economy, politics, and the alcohol industry might impact on harm experienced by poorer people. So I think it's clear from this diagram that several explanations are discussed in the literature. Given the number and the connections between the explanations, you could say that people working on this topic don't think that there's one simple explanation for the alcohol harm paradox. So that just brings me to my next point, the main findings of the review. So the first main finding was that there were several hypothetical explanations, as we've just seen in the previous diagram. However, a major finding of the review was that the empirical research had largely focused on risk behaviours, so the contribution of alcohol consumption, smoking and diet, while very little research looked at the many non-behavioural explanations, such as access to prevention and treatment services or a lack of material resources, which were presented as proposed explanations or discussed on an ad hoc basis throughout the literature. So I've covered what the alcohol harm paradox is and given some insight into what explanations have been looked at by alcohol researchers. And so if we just break here for a discussion about what you think contributes or causes the alcohol harm paradox before moving on to the next section.
Fantastic. Thank you very much, Jen. I think that raises actually a huge number of questions which we could probably be here the whole rest of the afternoon discussing. And it's such a fascinating topic. And in terms of inequalities, I know that often, particularly in the media, the kind of the go-to place for health inequalities that will be focused on is Glasgow. And I noticed, you've had a few slides relating to Glasgow there. And one of our participants has asked kind of why Glasgow? Was it just the obvious choice? Were the starkest differences there? What was your thoughts?
Why did I show the graphs? So the main reason I showed those graphs is the Understanding Glasgow project has all of those resources really readily available. And you see that relationship. I could have shown a graph of England, and it's from ONS data, and that's one that I use in other presentations. But they show harm alongside consumption. It can be a bit more difficult to interpret that graph. Whereas the one from Glasgow is split by consumption in one graph and deaths in the other. So it just makes it a bit easier for everyone to see, but that relationship isn't specific to Glasgow. That relationship exists in different countries. Like I said before, Australia, other parts of the UK, Wales, and everything. So there's a number of countries where that same relationship's found. So that's just one example.
Yes, thank you. I'd like to ask Lindsay Murphy if you could unmute yourself and just ask you'd put in the chat some comments related to materialism and income. Lindsay, would you be able to just expand on that?
Yeah, I was just thinking about, can people hear me okay?
Yep.
Great. Yeah, I was just thinking about the materialism and, thinking about those health literacy associations within public health. We tend to associate people who are more affluent with maybe better opportunities, better education, and generally these people, as well, if I make a generalisation, are better equipped to identify when they've got something wrong or identify health issues and then know exactly what to do and actually take the action to go and respond. So it was just another thought in that process that perhaps if these people are more able to identify healthcare needs and respond appropriately to them, it could then reduce the longer term harm as well because they're identifying issues at an earlier stage. Just a thought.
That's really interesting. Yeah, I think it's really useful to think about these things because I guess I'm coming from very much a research point of view, but it's really useful to start getting those sort of contributions about how it would actually work in public health practice.
Yeah, I've got some background in health literacy, and that's, it was about how people identify their healthcare needs as well, and do they know what to do if they do notice something's wrong and have the confidence to attend services, etc.
Thanks very much, Lindsay. Now, I'd like to ask David Barber, can you unmute yourself, and then I'll go to Harpreet Kohli. David, you have posed a question about kind of the environments people are drinking in. Can you just expand a little bit about that?
Yeah, so Jen, you mentioned that there was some hypothetical thinking that maybe poorer people were drinking in more dangerous environments. So when you said that, did you mean kind of maybe drinking in places that they might be more likely to experience either unintentional harm or violence, or be involved in either of the two? Or were you more talking physical harm because of the actual alcohol they're consuming?
No, about the physical violence and things as well. Yeah, I think it was, if I remember correctly from the review, there was a WHO report and it was talking about being in that environment that could, lead to violence, or there's other sort of risk behaviours going on as well, like drug use and things like that can compound the effects of harm. So, alcohol and harm.
Yeah. Thanks very much. Harpreet,
thanks very much.
Asking just in terms of a kind of comparison with low-income countries.
Yeah, Jen, thanks very much for that. I just wanted to pose two questions. One was, does the alcohol harm paradox hold for low-income countries? From a personal perspective, I don't see any reason to think it would not. But also, when you're looking at explanations, can you separate more comorbidity due to structural inequalities in societies as opposed to the health behaviours per se as an explanation for the paradox?
Yeah, so in reference to the first point about other low-income countries, that's not something that I've looked at in my research thoroughly, so I'm not 100% sure of that literature. I can totally see your point. I think that it would make sense that the same relationship exists there. So you might even see some sort of, if you looked at high-income countries versus low-income countries, that might be quite an interesting comparison to see how it matches up. And I'd be interested to see more work in that area. The second point that you raised about how you can separate health behaviours from structural factors, is that the...
Yes, and structural factors causing comorbidity in individuals and populations as an explanation for the paradox, as opposed to purely health behaviours.
Yeah, so in the next part of my talk, I'm going to speak about the main sort of paper that we've now written and we're in the process of finishing writing up, which kind of looks at using social determinants of health, fundamental cause theory, and a number of others to see how we can look at it in a different light. And that'll be the next, this next section of the talk will be focused on that.
Okay.
We kind of touch on the fact that the social determinants of health not only influence health itself, but also health behaviour. So that will, come
Thanks.
up. No problem.
Thanks very much, Harpreet. I'm just having a look through some of the other kind of questions and comments that we've got posed. There's one from Ewan McKinney, who's asking about kind of alcohol marketing in terms of being an upstream activity. Jen, is that something that is maybe kind of something you'll be addressing later on, or is that something you could talk about just now?
Yeah, so in terms of the marketing, I don't think I really touch on that in the later sections of this talk. I think the influence of the alcohol industry and marketing is really interesting. Again, it's not something that I know about in depth. I've kind of been really focused on this sort of epidemiological relationship and then trying to look at it in a different light, but using the theories of health inequality. But I do think that there's definitely something interesting going on there. And I'm maybe not the best person to comment. Maybe someone knows a bit more about this who's in the session today, but I think it's really interesting.
Is there anyone who'd like to chip in just now about kind of marketing and how it might be directed towards lower socioeconomic groups in terms of alcohol marketing? I'm trying to see if anybody's got their hand up. If I can scroll through. No, I don't think anyone has. Shout out if I've missed you out.
Lindsay, can I just come back in there a little bit?
Yes, go ahead, David. Yes.
I was purely just wondering about the fact that obviously there's been a lot of talk about gambling advertising with football, and just the whole idea of like football being the working man's game and alcohol advertising in football. I don't have much more to say other than I wonder if that might play a role as well to some extent.
Yeah, that's a really interesting point as well, and I mean that's quite often in the media at the moment in terms of I know that one vodka company recently sponsored one of the, I think, Premiership teams' kind of football kit, and yes, it's certainly an ongoing discussion for all of us in this area at the moment. So I think in terms of our timings, I think if we're going to keep on time, it's probably about right that we move on to our next session of the presentation with Jen. But at the end, remember, we'll have an opportunity to do a kind of mopping up of any unanswered questions or anything else that's come to light throughout our event just now. So I will hand back over to Jen for part 2.
Okay, so yeah, that was really interesting. Thanks so much, everyone. So moving on to the next major section of the talk, how can health inequality theory help us understand the alcohol harm paradox? So again, I just wanted to highlight some key points that I hope you'll take away from this section of the talk. The main thing would be to go away knowing that the alcohol harm paradox is an issue of health inequality. And the other thing would be to have a basic understanding of some key health inequality theories that could be used to understand the alcohol harm paradox. And I'll talk about the social determinants of health and fundamental cause theory. So I just wanted to bring your attention back to the quote from Margaret Whitehead I used at the beginning to define health inequality. I think that part of the issue why research investigating the alcohol harm paradox has been so focused on behaviour comes from the fact that alcohol harm hasn't been situated as an issue of health inequality. So health inequality, as Margaret Whitehead defined it, are systematic differences in health systematic differences in health between different socioeconomic groups within a society which are socially produced and therefore potentially avoidable and widely considered unacceptable in a civilised society. So the consistent observation that lower socioeconomic groups drink the same or less on average, yet experience greater rates of alcohol harm is a clear example of health inequality. Not only this, but recent evidence suggests that alcohol-specific deaths greatly contribute to inequalities in life expectancy and variation in death age between socioeconomic groups. It's clear the two are interlinked. The alcohol harm paradox is undeniably an issue of health inequality, yet we've missed the key feature of health inequalities, that they're socially produced. And there's a breadth of existing literature which aims to understand health inequalities, which has looked at the social causes, but these have yet to be applied to understand the alcohol harm paradox. So that brings me to the need for our paper. The main purpose of the paper is to identify other ways of understanding the causes of the alcohol harm paradox, and therefore the solutions that are not only focused on individual behaviour. Particularly given that the alcohol harm paradox is an example of health inequality, we explore how existing health inequality theory could help us to understand the alcohol harm paradox. And this is important because alcohol research generally, and research investigating the alcohol harm paradox, has been dominated by studying behaviour or risk factors. And using a behavioural or risk factor approach inherently gives greater weight to factors close to the individual, such as health behaviours, and can neglect the wider context in which health harms occur. So based on the evidence, an individualised behavioural approach isn't sufficient to explain the complex relationship between socioeconomic position, alcohol consumption and harm. And that's not to say that alcohol researchers don't acknowledge that this is an issue, and there have been calls from alcohol researchers in the last year to explore contextual factors which may contribute to harm. So for example, the drinking environment, neighbourhood and policy contexts. This increased appetite to shift from focusing on individual behaviour to understand alcohol harm outcomes in alcohol research is another reason why this paper is needed. We chose to write the paper as the first step to unite the literature on health inequality and research on the alcohol harm paradox, and hope that it would encourage alcohol researchers to use some of these theories in future research. So what are theories of health inequality? Well, a theory is essentially a group of linked ideas which aim to explain something, and they can provide a framework for explaining observations. So a theory of health inequality, for the purposes of this paper, are explanations for the systematic differences in health between different socioeconomic groups. And we didn't aim to give an exhaustive overview of the different theories or explanations of health inequality in the context of the alcohol harm paradox. Instead, our aim was to identify the merit of applying a wider perspective in alcohol research, specifically to understand the complex relationship between alcohol consumption, wealth, and alcohol harm. We decided before writing the paper to focus on 4 main theories of health inequality: the social determinants of health model, fundamental cause theory, the political economy approach, and the ecosocial model. And given that this is a lot of content to cover, I'm just going to focus on the first two for this talk, the social determinants of health model and fundamental cause theory. So the key steps that we took in the paper to bring together the theories of health inequality and the literature on the alcohol harm paradox were as follows. First, by introducing the theory, so outlining the main ideas and concepts within that theory and the processes through which the concepts work to produce health inequalities, often illustrating it with an example. Followed by then exploring the extent to which the theory was already present, and this could be implicitly, in the literature on the alcohol harm paradox. And for this second step, I drew on the results from my previous review. And finally, by examining how the theory could be used to explicitly frame research, often by providing examples taken from other areas of health research where the theory had been implemented to understand another health outcome. As this was how we presented the information in the paper, I'm going to take a similar format in this talk. But first, before I do that, I think it would be good to briefly discuss each theory, particularly the key features of the theory and how they differ from one another. So the social determinants of health is a multi-level approach which considers everything from individual behaviour and psychological processes to the structure of our society in the form of public policy and services. And so there are four main explanations within the social determinants of health, including culture-behaviour, which considers the role of shared group health behaviours, the materialist explanation, which focuses on the role of material wealth and resources in determining health, psychosocial explanation, which focuses on how being poor makes people feel, and the psychological experience of comparing yourself to others who are better off in society and how this can negatively impact health and finally the Lifecourse explanation, which takes the risk factors specified in the other three explanations and then situates them in time to explore critical time points in a person's life, such as childhood and the accumulation of risks throughout their life, which impacts health. Fundamental cause theory is quite different from the social determinants as it looks beyond risk factors in health to attempt to understand what it is about being poor that puts people at risk of risks. It's rooted in this idea that there are fundamental resources, so things like money, power, knowledge, social connections, and prestige, which determine whether an individual will have the ability to adapt to new health information or uptake new treatments, and those with access to a flexible pool of resources can adapt, and those who do not have access to these resources cannot. And this results in the health gap between the rich and the poor. So the social determinants of health is one of the most prominent theoretical approaches to understanding health inequality and generally refers to the social and economic factors, for example, social support and employment, that shape health at the individual and population level. Several explanations fall within this approach as it looks at the interacting role of factors in determining health inequalities from the narrowest sphere, so for example, how poor people feel when they compare themselves to others, to the broadest level, so for example, looking at how the structure of society influences health inequality. It attempts to shift the focus from individual level behaviours as the cause of health inequality to social determinants, which themselves determine not only health, but also behaviour. And several more specific explanations fall within the social determinants of health. And these are cultural behaviour, materialist, psychosocial, and Lifecourse. So the cultural behavioural explanation focuses on the impact of lifestyle behaviours as the cause of differences in health outcomes between socioeconomic groups. And those who advocate for this explanation suggest that culture and behaviour share a reciprocal relationship, with each determining the other. This idea comes from evidence of a gradient in health behaviour across socioeconomic groups. So for example, poorer people are more likely to engage in smoking, poor diet, and low levels of physical activity than richer people. However, this gradient in health behaviour more recently has been argued to be a consequence of disadvantage. So the conditions of disadvantage, for example, greater experience of stressful life events and greater availability of fast food restaurants in poorer areas, then fosters the adoption of unhealthy behaviour and decreases poor people's opportunity to engage in healthy behaviours. Therefore, although in the past the cultural behavioural explanation was argued to be a clear cause in itself, it's now recognised as also a symptom of inequality. So materialist explanations focus on the link between wealth, resources and health, and it's clear that differences in material wealth determine access to transport a healthy diet, good education, housing, and the ability to be an active member of the community, all of which are known to lead to better health outcomes. Your material wealth determines where you live, and this can be in health-promoting or health-damaging environments. This explanation not only focuses on wealth of individuals and how that contributes to health, but also acknowledges the role of public policy and services, which have two parts to play. The first being that it determines individual wealth, so for example through the benefit system, and the second is that it can also bypass the role of material wealth, especially if there's a greater availability of public services which can be accessed by all. Psychosocial explanation, on the other hand, is concerned with how people view themselves in comparison to others in their society, their perceived social status and the resulting psychological and biological consequences, which determine health. The psychosocial explanation is quite different from the materialist explanation, as it's more concerned with the psychological experience of those living in deprivation and how that impacts harm. Those that have investigated the psychosocial explanation in other areas of health research have established that poor people feel subordinate and inferior to rich people in their society, and this has been shown to increase the stress they experience, which has negative impacts on both physical and mental health, particularly when the stress is prolonged. This explanation is unlike the others I've spoken about, as it places a greater emphasis on how people feel rather than looking at a simple relationship between exposure and risk. The Lifecourse is quite different to the other explanations I've discussed, as it integrates aspects of several other explanations and allows you to look at different explanations for inequalities in health between poorer and richer groups. To an extent, it's not in itself an explanation, but instead it emphasises the importance of timing and looking at the whole picture of someone's life rather than a snapshot. It's not limited to a single generation and has an element of biological and social transmission of risk across generations, so it also considers things like how your parents' circumstances might impact your health in the future. This approach focuses on the exposure to risk factors, which are taken from the other explanations I've previously discussed, and looking at the role of these risk factors from the very early stages of life to old age, and the accumulation of risk over time, which is argued to result in health inequalities. So now I'm going to talk about how in the paper we looked at applying these theories. So based on what I discussed in the previous section, we know that behavioural explanations have been key to research investigating causes of the alcohol harm paradox. And differences in health behaviour between the poor and the rich have been tested extensively. This research has demonstrated that heavier drinking patterns and engaging in multiple unhealthy behaviours contributes to the harm experienced by poorer people. However, in terms of the cultural component, culture and norms being the rules or expectations for certain behaviours when belonging to a group, have only been hypothesised to impact alcohol-related harm. Future work could try to look at the interplay between culture, norms and behaviour by investigating occasion-level risk factors, so for example, drinking context. And this is about the why, when, where and who of drinking, which may differ between socioeconomic groups and impact on harm outcomes. The materialist explanation has not yet been tested by research examining the alcohol harm paradox. However, individual material deprivation in the form of housing and employment has been proposed to lead to worse outcomes, as having a lack of resources means that poorer people can't protect themselves from a problem or stressful life event. Additionally, place-based deprivation, so for example, dangerous drinking environments, a lack of treatment facilities and preventative services, greater alcohol outlet density, and barriers to accessing healthcare have all been hypothesised to contribute to the alcohol harm paradox. One way the materialist approach could be used to understand the alcohol harm paradox is by measuring the resources available in the environment, as well as individual resources such as wealth. This could reveal the role of environmental resources in determining differences in alcohol harm outcomes between socioeconomic groups. Additionally, we could look at individual and environmental resources within socioeconomic groups to better understand how these play a role. This could identify whether, how, and to what extent materialist mechanisms cause and sustain the paradox. Psychosocial explanations have also not been tested in the existing research on the alcohol harm paradox. However, mechanisms associated with this explanation have been proposed to play a role, particularly the idea that lower socioeconomic groups experience a greater number of stressful life events negative stereotyping, stigma, and social isolation. And this then leads to a lack of social relationships, which is thought to result in worse coping strategies. So, for example, using alcohol to cope. The psychosocial approach could be used to understand the alcohol harm paradox by using social capital measures, which aim to measure the extent to which your social network can protect you from stressful life events, so something called social buffer, and also capture the negative impacts of feeling excluded from your society. Social capital focuses on the effective functioning of social groups through things like shared norms, identity, values, trust, and belonging, which represent the productive benefits of sociability and have been used extensively in research capturing how the psychosocial pathway contributes to health inequalities more generally. So researchers investigating the alcohol harm paradox have used the Lifecourse approach to situate risk factors in time, specifically those risk factors associated with other social determinants of health explanations. This research has shown promise, with one study finding that cumulative behaviours, so drinking and smoking, that persist over time, explain a greater proportion of the risk of mortality compared to just looking at current behaviour. Another study demonstrated that material deprivation in childhood led to an increased risk of developing a comorbid alcohol and mental health condition in later life. In terms of what was hypothesised by alcohol research but not tested, it was said that the accumulation of stressful life events throughout the life course played a role in the alcohol harm paradox. And one way to implement the Lifecourse perspective in research on the alcohol harm paradox would be using retrospective data. And this is data that's been recorded anything after the event, and in this case it would be an alcohol-related event. So the investigator goes back to the past to select a study group from existing records and looks at their past employment, medical, and other records, and then traces them forward through time to identify risks. Another theory that we examined in the paper is fundamental cause theory, and this theory aims to shift the focus from individual level causes such as alcohol consumption to looking at the context, so what puts people at risk of risks. This essentially means acknowledging that the risk factors themselves are generated by social conditions, specifically the socioeconomic stratification of society. Central to fundamental cause theory are resources defined as power, money, knowledge, access to social connections, and prestige. And these resources associated with socioeconomic position determine whether individuals have the ability to adapt to the introduction of a new disease, risks, or treatment. And it's proposed that high socioeconomic groups have increased access to these flexible resources, and they can employ them to avoid risks and reduce the consequences of disease and uptake available treatment to improve their health. In contrast, these resources are not as readily available to lower socioeconomic groups. And I'll just talk a bit more about how we thought of applying this theory. So fundamental cause theory wasn't apparent in research investigating the causes of the alcohol harm paradox. Using this theory to frame the mechanisms underlying the paradox requires a focus on the societal structures which generate social inequality by impacting the availability of key resources, including money, power, knowledge, social connections, and prestige, rather than the causes at the individual level that are common. Fundamental cause theory has been tested in research by comparing two different diseases, both of which can lead to death. A method called comparative case study was used, and one example of this kind of study compared lung cancer to pancreatic cancer. And the idea was that when the disease becomes more preventable, so for example, for lung cancer, there was a discovery of risk, that if you smoked, you had a greater risk of developing the disease. Then as we learn more about prevention, those with greater access to resources disproportionately benefit, and therefore health inequalities increase. This is certainly true in the case of lung cancer versus pancreatic cancer, as death from lung cancer has decreased for those of a high socioeconomic position, despite being higher prior to the discovery of the link between smoking and lung cancer. And this isn't seen for a disease which lacks major prevention or treatment innovation, and in this case, pancreatic cancer, and there's found to be no mortality advantage between socioeconomic groups. So this graph illustrates what I was just discussing in the previous slide. It shows the lung cancer mortality in the richest, so the high socioeconomic group, middle and poorest groups in the United States for men aged 25 to 64 and over from 1950 to 1998. So the key thing to take away from this graph is that before 1974, the richest group actually had the highest rates of lung cancer mortality. And it is around that time that the risk between smoking and lung cancer was made widely known. Following this, the richest group's rates of lung cancer mortality began to flatten and then decline much sooner than the rates for the middle income group or poorest group. This lagged effect of decreasing lung cancer mortality is thought to be the consequence of social processes which determine whether the health relevant information and technology is effectively deployed and how long it takes to spread through populations. Additionally, once the capacity to address disease and death has been placed in human hands, those hands deliver the benefits unequally, so that individuals with more resources of knowledge, money, power, prestige, and beneficial social connections benefit more. So just to summarise the theories I've just discussed, the social determinants of health is a multi-level approach which considers everything from the individual behaviour and psychological processes to the structure of our society in the form of public policy and services. And there are four main explanations within the social determinants of health, including cultural behaviour, which considers the role of a shared group health behaviours such as the fact that poor people are more likely to smoke. However, this explanation is now seen as both a cause and a symptom, in the sense that the environment to an extent determines health behaviour. The materialist explanation, which focuses on the role of material wealth and resources in determining health, it's about how income and housing, amongst other things, can either protect or worsen health. And this explanation also looks at the role of public policy and services which can determine and circumvent the impacts of material resources on health. The psychosocial explanation, which focuses on how being poor makes people feel, the psychological experience of comparing yourself to others who are better off in society, and how this can negatively impact health, and the Lifecourse perspective, which takes the risk factors specified in the other three explanations and situates them in time to explore critical time points in a person's life, such as childhood and the accumulation of risks throughout their life, which then impacts health. The key thing to note about the social determinants of health is that it doesn't hold one explanation up as better than the rest, but acknowledges that each of these explanations interact to generate health inequalities. And to summarise fundamental cause theory, it's rooted in the idea that there are fundamental resources, which are power, money, knowledge, social connections, and prestige, which determine whether an individual will have the ability to adapt to new health information or uptake treatments. And now, so again, I just thought it would be good to pause here and have another discussion about that second section of the talk.
Thanks very much, Jen. That is certainly a lot, gives us a lot to think about. And just following through the chat, I mean, there's a whole lot of themes coming out of the discussion in the chat, including more about the impact of pricing, about marketing, whether, you know, rather than there being a focus on health inequalities as such, it should be just social inequalities. Also issues about things like the density of outlets in lower socioeconomic areas, which is something I find really fascinating. And obviously as well, kind of what impact has the pandemic had on things, kind of in more recent months, and has it kind of disproportionately affected people in lower socioeconomic groups. It's difficult to try, and I'm not sure, unfortunately, we'll be able to get through everything in the time we have left. But in terms of, I think probably one of the main ones, I mean, particularly in Scotland, where we have minimum unit pricing, you know, that remains something that, you know, I mean, SHAAP as an organisation, we are, you know, value pricing as a, you know, kind of preventative method very highly. So in terms of pricing, what do you think, Jen, that kind of what role does that have to play, do you think?
Yeah, so I think in the next section we'll talk about like policy and research impacts from using health inequality theory. But I think the minimum unit pricing is definitely a step in the right direction as well, because you are targeting those more deprived groups. And John Holmes, who I think is on the call, will know more about this than me, and maybe some other people in the audience would want to talk a bit more about this, but yeah, I think that having sort of more targeted policies and interventions to obviously alcohol consumption does contribute in some way. It might not explain the whole paradox, but it's a start sort of thing. So yeah, I don't know if anyone wants to pick up anything on that.
Does anyone want to put their hand up in terms of if they have any comments on kind of pricing and impact and how I see David, you still have a hand up, but I think that might be a legacy hand, David Barber. Okay. Well, if we think about if I can maybe just I'll bring somebody in. So okay. I see Melissa Oldham has been sharing some information in the chat as well. Melissa, are you there?
Yes, I am.
Hi, Melissa. And you have published a paper about drinking in lockdown. Is there more to this than meets the eye, do you think? What's does the paradox always apply? What are your thoughts?
Well, one of the papers that I've posted is Claire Garnett's paper, who's here as well. So correct me if I say anything wrong, Claire. But that paper shows that actually there's different groups which are drinking more and different groups that are drinking less. So we know that drinking has polarized in lockdown, and some of the people who are drinking more seem to be heavier drinkers to start with and of higher SES, whereas those groups who are drinking less as a result of lockdown tend to be lighter drinkers and also people from lower economic groups. So I can't really comment kind of in relation to the paradox because I wouldn't feel qualified to, but that's kind of the pattern that we're seeing. So it would be interesting to kind of see how that affects, the kind of outcomes, because we know that there are groups who are more at risk of harms as a result of COVID and obviously more generally.
Yeah, I think that's really interesting, actually. I mean, I was aware of of research showing that if you were likely to be a heavier drinker, then you were drinking more during lockdown. But when it's becoming more kind of refined and detailed, I think it is. It's very interesting to kind of follow how it. The kind of pattern it's gone in. I see Diane has her hand up. Diane, would you like to come in? I think you're on mute.
Yes. Hi, Lindsay. Thank you.
Hello.
Yes. Yeah. I'm speaking from the point of view of a patient, and what I think is, especially during lockdown, when there's a certain amount of things that you can choose to help you get through it, the fact that alcohol is cheap means that it's one of the few things that you can resort to, and so I think that's quite an important point. I mean, it says that MUP, should be put into use in England, and in Wales and Ireland as well. I know it's in Scotland at the moment, but I think that's quite important when you're looking at socioeconomic groups, because if you don't have much money to spend, then sort of it's going to be what's available, and alcohol is one of the things that's available because it is cheap.
And from your own kind of personal experience, have friends who may have been drinking more anyway, if they've been drinking more in lockdown, would you say?
I would say, well, actually, because I'm in recovery, okay. I tend not to talk much about alcohol with friends, but I know that people have referred to alcohol as, yes, oh, thank goodness for alcohol. You hear that quite a lot. Well, sort of, if alcohol hadn't been here, I don't know how I'd have got through things, or I don't know how I get through things. So yes, I do think that it's something to be taken into account.
No, thank you very much, Diane.
Thanks.
So we're pretty much, I see there's much more coming through on the chat, but we're just going to go just now to the very last and short kind of 5-minute section of Jen's presentation, and then we'll have our kind of wider kind of Q&A discussion at the end before we wrap up the event by 2 o'clock. So Jen, over to you again just for the last part of your presentation.
So the last section I wanted to cover was just some thoughts on what the introduction of health inequality theory means for the wider alcohol research and policy agenda. So the major change for research in applying any of these theories of health inequality is moving from just trying to understand how behavioural factors such as alcohol consumption and other risk behaviours contribute to harm, to situating these behavioural factors in a wider context. So alcohol consumption and other behavioural factors do contribute to harm, and that's clear from the evidence, and we shouldn't stop trying to intervene to encourage healthier behaviours. But we do need to acknowledge that if we really care about reducing inequalities and alcohol-related harm, we need to do more and start to unpick what the other factors and processes that are present in the lives of the most disadvantaged that either exacerbate the effects of their alcohol consumption or independently contribute to their risk of harm. A possible way to achieve this could be through collaborations with other research fields. Alcohol epidemiology and epidemiology in general has been criticised for its focus on the idea that population health and disease is the result of the characteristics of the individual, and this greatly influences research design. Collaborating with others and within alcohol research and outside could open the door to alternative research designs which have not yet been used to examine the alcohol harm paradox. In terms of how this impacts policy, it's important to consider alcohol-related inequalities during the decision-making process. So many of the policies focused on alcohol have been on reducing consumption, which do improve population health, but also to an extent increase health inequalities between socioeconomic groups. Implementing policies which rely solely on individuals to reduce their consumption, so for example through educational campaigns, arguably increase inequalities as lower socioeconomic groups don't have the necessary resources to engage. And one possible solution is to target these interventions to not just improve the health of the population on average, but to narrow the gap between the best and the worst off in our society. And I'm sure there's a lot of work going on in this area. Another way to think about this issue would be to broaden the scope of the policies. So we know that there are other factors at play in creating the alcohol harm paradox, not just health behaviour. And policies which tackle broader issues such as education, employment and housing could be the key to reducing alcohol-related inequalities. So applying non-behavioural framings such as health inequality frameworks in the alcohol research field could result in a more structured effort which gets at the root causes of both alcohol-related harm and alcohol-related health inequalities. Taking a multi-level approach would allow the flexibility of understanding the role of other mechanisms in addition to alcohol consumption, which exist in the wider socioeconomic environment and contribute to alcohol-related harm. This is the potential to inform policymakers to not only aim to reduce consumption, but to reduce harm and inequalities in harm. And this may require a perspective shift to focus on policies out with traditional public health behavioural interventions, such as education campaigns, to looking at broader social policy changes. And this shift already seems to be occurring with calls by alcohol researchers to look beyond alcohol consumption in investigating the alcohol harm paradox. So finally, the take-home messages from this webinar is that we know that inequalities in alcohol harm exist, and this is further complicated by the fact that alcohol consumption can't explain the differences in alcohol harm between the poor and the rich. One alternative approach that should be used to try to understand the causes of the alcohol harm paradox are theories of health inequality. And there are several theories of health inequality which focus on different factors and emphasise different processes which generate health inequality, but they all have one thing in common: a shift from investigating individual level and behavioural factors towards taking a multi-level approach rooted in social causes of health. I hope from this webinar you now think of using health inequality theory as a potential way to think about inequalities in alcohol harm and possibly other areas of alcohol research, given that health inequality theory proposes that these factors don't just impact health itself, but can also determine behaviour and therefore alcohol consumption. So thanks very much for listening. I'm really looking forward to the last part of the discussion and hearing your thoughts. And I'll actually just stop sharing my screen, I think, as well.
Great, thank you, Jen. I know you finished up there by saying, you know, it's definitely kind of multi-level approach rather than individual. And I mean, throughout the presentation and, you know, our discussions that we've been having and in the chat, it really is apparent, you know, this is absolutely kind of multifaceted. There's so many different things involved here, which I think is why so far, you know, it's been a struggle to make progress. And because how do you kind of tackle all of these things? So I see we've got a couple of hands up. So Fahad, would you like to come in? Is your hands up? Fahad? Oh, is he straightening up his, or no, maybe not. He's taken his hand down. Okay. David, have you put your hand up again? Yes. Okay, David.
Yeah, just Viv had obviously mentioned about maybe focusing more on the social determinants. So I also work with the Scottish Community Safety Network. So I'm not as au fait, I'm the comms officer there with these issues, but I'm just wondering, even to take back to my organisation, about what role maybe community safety partnerships or community planning partnerships might play, thinking about the sort of place standard and creating communities that where people feel safer, more secure, where they have a better access to amenities, more, whether that's good transport links, outdoor spaces, all these kind of things. And is that a way of looking to tackle harm in lower income groups? I mean, I think it is, but
yeah,
what are your thoughts on that?
I'll just say a wee bit and then Jen, hand over to you. I mean, personally, I absolutely agree with that. And again, it is not an easy thing to achieve, which I think why often it hasn't really kind of been pursued. But we need to really kind of go for everything, you know, planning, you know, education, lots of different, you know, departments through councils and government. It's absolutely lots of multi-department kind of response that's needed. Jen, would you like to add in there?
Yeah, no, I completely agree with what David said as well. I think this is kind of, to me, seems like the start of kind of really getting to grips with, okay, well, we now people kind of now are accepting, okay, it's not just about alcohol consumption in terms of the alcohol harm paradox, and that it's now about kind of keeping that momentum to try and do things and look at the broader determinants. And a really good point was raised a couple of days ago to me about, well, if you look at different theories of health inequality, maybe that impacts different alcohol harms as well, because if you're looking at acute harms versus chronic harms, you know, so I think this is just kind of the beginning really of kind of figuring that out. And I think it's really well that as researchers we think about the practical side of it as well, and how we can work with people who are out there and can make sort of difference and have those services available to think about that as well. So yeah, thank you, David, for that.
Fantastic. Wayne, would you like to come in?
Hi, Jen. Thanks ever so much for your presentation. I really enjoyed it. I'm the lead officer for the Aberdeenshire Alcohol and Drug Partnership, and one of or a couple of questions sort of begged by your presentation for me relating to alcohol licensing. Most folk will realise or have some appreciation of how difficult this area is. Very few examples of where the alcohol licensing regime has actually changed things much for the better in relation to the things that we're talking about just now. And a couple of reasons for, or one major reason for that is the government's insistence that the guidelines includes a requirement to have a causal link between alcohol sale and alcohol difficulties. And if we're saying that actually the harm paradox isn't about necessarily consumption levels, it's about fundamental things beyond the kind of regulatory or alcohol sales regulatory environment, does that actually make our position harder to argue?
I think that, yeah, that this is a worry, because I think clearly alcohol consumption does have a role, and as alcohol, you know, people that really care about this sort of thing, we don't want to give, you know, the lead to be like, oh, well, alcohol doesn't matter at all, because I think it still does matter. It's just that we can't just look at alcohol if we really care about inequalities. We have to look at the other things that I spoke about today, the social determinants, fundamental cause theory, and maybe other people have other ideas of ways to look at this. So I think it's less about saying, oh, alcohol consumption doesn't matter anymore. Alcohol consumption does still matter. It's just that we need to start thinking bigger if we want to reduce inequalities. So, yeah. If anyone else wants to come in on that point as well.
Would anyone else like to come in on that particular issue? Well, just now I'll just pop across to Bruce Ritson. Lovely to see you. Would you like to? Have you got a question, Bruce? Are you? Oh, you need to unmute. Bruce, can you unmute? Oh, we're trying to unmute. Right. Well, for just now. Oh, here we are.
I think I've unmuted.
Yes, you have, Bruce. Well done.
Can you hear me?
Yes.
I thought I sort of an excellent review of the situation. Of course, I absolutely agree that we need to look much more broadly at this. You've got going way back to the Black report, then 2 Marmot reports, all showing that health and social disadvantage is are very closely related. There's a very steep gradient. It also, many of these studies have also shown that the discrepancy between the rich and the poor is an important predictor of morbidity. So that where there is a slightly smaller gap than we have, then you have less of a problem. I wonder if you had any. But one is, do you have any thoughts about grading between, and also how do we turn this need for many different departments to be involved in this? And indeed, it's not just alcohol, it's many other health problems. It seems to point to a need to collaborate. Maybe it's something the College of Physicians could do, but then that's only health. You could say the same for crime and many other things. So any thoughts about that?
Jen, do you want to?
I wasn't sure if you
go
first. Yeah, thanks, Bruce. That's really interesting. You cut off a little bit when you were asking the first question. I think it was about the gradient of health between the groups. I wasn't quite sure what.
Yeah, that's right. Yes.
Yeah. So in terms of like.
I'm on a not very satisfactory machine here, but I'll try and speak up. Yes, that was it.
That's okay. In terms of alcohol related and specific deaths, there's also that gradient. I think that was the graph that I showed displayed at the first section of the presentation. So it's clear that there is a sort of stepped relationship, and that's kind of throughout like all health and also alcohol related deaths and specific deaths. And then
I was thinking about the gradient of income. Because in Scotland.
Okay, Bruce, we've lost what you're saying there. Jen, was there anything else to add to what Bruce was asking while we still had him?
I'm not sure what the second thing.
Okay.
Sorry.
Sorry, Bruce, it's a bit of a bad connection. So one thing I would actually like to do is to ask John Holmes if he's still here, just to say hello, who works with Jen at the University of Sheffield and has been posting some very interesting comments, particularly about kind of pricing and things in our chat. Is there anything kind of as an overview at the end you'd like to chip in, John?
Yeah, I guess the main point on pricing is that pricing policies do generally have a bigger impact on people on lower incomes. So they are a way of reducing the health inequalities caused by alcohol. And there's always a debate about whether tax penalises the poor. And that's true to a certain extent. But if you want to reduce the health inequalities, you've got to, partly at least, reduce drinking among people of lower incomes. Obviously, there's the various points Jen's been talking about tackling wider social problems. But one of the other points is that minimum pricing is particularly well targeted for addressing health inequalities, because it targets the cheapest alcohol that's drunk by the heaviest drinkers on low incomes. It doesn't particularly affect the people on low incomes who are only drinking at low levels. So the work we did that was published in The Lancet showed that 80% of the health benefits, so the mortality reductions and the reductions in hospital admissions, accrue to the 40% of the population who are in routine and manual worker households. So this is a very good way of tackling the health inequalities, as well as tackling these wider social problems that Jen's pointed towards.
Mm-hmm. Something which I'd like to just ask our audience just now, is anyone kind of aware, and sorry, thank you very much, John, for that, because I think pricing remains one of our key things that we can take forward in tackling problem drinking. So thank you very much for that, and I think you posted some links and email in the chat if anyone's interested in work that John and Jen are doing. I think Jen's also just completed another paper which will be published, so we'll be keeping a close eye out for that. So yes, sorry, is anybody aware of kind of particularly good examples of where they are of, for example, kind of different departments coming together to, whether it's new housing being built, that includes kind of good community centres, lots of green space, good things kind of happening which are actually kind of improving like living environments and things that they feel are kind of contributing to an improvement in terms of kind of health inequalities and things like that. Any best practice people can share examples of on a kind of whole environmental level, multi-departments working together. It's definitely I think the kind of multi-department working seems to be kind of the way forward, I think.
Lindsay, I could just say that I'm fairly certain, or like was saying, that there would be examples I could find as well if I spoke with my community safety, community planning colleagues that are going on, because I know the place stand-up tool has been adopted by a lot of local authorities as a way of trying to address that. So, but I just can't think of any off the top of my head.
Sure.
Sorry.
Yes, I know putting people on the spot is yes, not always the easiest thing. So so I think we could, I think, go on for a long time with all the different aspects of today's discussion and all the really interesting topics that Jen's presentation has kind of brought to the fore today. But as we're approaching 2 o'clock, I think I'll just begin wrapping up. So on behalf of all of us, and I mean, really, it's very apparent from the chat that people have been, really interested in Jen and Jen's presentation, and we still have well over 100 people here at the end of the event, which just goes to show that people have remained kind of engaged, interested in what's been going on. So I mean, I think that's fantastic, and I mean, it's just so apparent that there's a lot more work to be done in this area. And there's so many different ideas and comments that came about today. It was something which I thought was a very good discussion, and unfortunately just with time restraints we couldn't cover quite as many different topics as were being kind of shared. So really it just is left to me to say thank you to all our audience members for joining us today. And of course, thank you so much to Jen, and we're looking forward to following your research with interest. And I know, of course, later on this afternoon there's another big event which will be competing for attention today. So we'll be finishing well in time for anyone else who's interested in that this afternoon. This year our Alcohol Occasional programme is really a bumper year, actually, because we've had so much interest in this kind of line of work that we do, and our next Alcohol Occasional will be on a different day of the week, a Thursday, but at the same time 12:30 on the 25th of February. So that's a date for your diary, which will be exploring men's alcohol consumption in the context of becoming a father, a scoping review. And actually, I think in the chat, it might have been Melissa, might have actually been doing similar work to that as well. So we're looking forward to hearing from Dr. Elena Dimova of Glasgow University on that event on the 25th of February. And then we have further events on the 30th of March, 28th of April, 1st of June and 15th of June. So we have been very fortunate that there's been a lot of interest and excellent proposals this year. So we're hoping that we'll continue to have a great turnout at our future events. So I think it just comes down to saying thank you very much for attending. It was great to see everybody here, and take care. Thank you so much. Thank you.
Thank you, everyone. Thanks for listening. Thanks.
Thanks, everybody. Thank you.
Thank you.